how we are often be challenged and faced with the task of managing these patients in the intensive care unit. And the volume is going to just keep increasing throughout the next few years. The mortality of these patients, as it is shown in this slide from the Society of Thoracic Surgeons Congenital Heart Disease database, is actually quite significant. Um, and nice mortality table specific to congenital heart disease shows that even simple surgeries like an atrial septal defect repair, congenital heart defect repair, pulmonary valve replacement, which are very, very common in the United States, account for a significant amount of in-house mortality, especially if we compare these procedures with other procedures we see in non-congenital adult patients, like cabbages or valve surgeries. So there's still a significant amount of outstanding mortality that these patients are faced with, unfortunately. So when we manage these patients in the ICU, I always like to go back to like the basic principles of physiology, because truly what we're trying to do in a cardiac patient in the intensive care unit is to optimize oxygen delivery and oxygen consumption. And we want that balance to be as close to physiologic as possible. And this equation, the oxygen delivery equation, that states that oxygen delivery is equal to cardiac output times the arterial oxygen content of blood, is actually like what we try and improve on a daily basis in the intensive care unit. So let's look at the main determinants of arterial oxygen content. The main determinant is actually the hemoglobin and its saturation, whether we measure it by ABG, so SaO2, or whether we measure it non-invasively with a pulse oximeter, SpO2. The equation you guys see, the 0.003 times PaO2, actually that is not important in the intensive care. In fact, I go as far as saying that I personally do not care what the PaO2 is of my patient, in the sense that PaO2 is important to guide prognostic assessments, for example, regarding the severity of the ARDS of a patient. But when we're trying to optimize oxygen delivery in a cardiac patient, especially a congenital cardiac patient, all I care about is the hemoglobin and saturation. So I want to know the baseline hemoglobin of this patient, and I'm trying to optimize the saturation of that hemoglobin. So we all need to remember that hypoxemia is not the same thing as hypoxia. So we can see here that normal oxygen delivery is about 15 mLs per kilo per minute in a healthy adult. Normal oxygen consumption is about 3 mLs per kilo per minute in a healthy adult. And we can see this curve, which is the balance, the physiologic balance between oxygen consumption and oxygen delivery. And where the two actually meet is at a venous saturation, a mixed venous saturation of about 80%. So to kind of stress what patients with congenital heart disease can teach us, not only about management of cardiac diseases in the intensive care unit, but also management of ARDS patients. I have these two monitors on the slide. And, we have, let's think about this imaginary case of having two twins in the ICU. They're both in our ICU, one next to each other. And heart rate of the twins is the same, 110 beats per minute. But one twin is satting 55%. The other twin is satting 90%. Okay. And, I'm going to ask you a question. Who do you think is doing better in terms of oxygen delivery? We need to have another piece of data to be able to answer this question, right? By physiology, we need to know what the hemoglobin is, right? So in the first patient that is studying 55%, which is a number that would essentially push any intensivist to be at the bedside immediately, doing something about the patient and delivering high FiO2 to the patient. Our hemoglobin is 12. In the second patient, citing 90%, by most accounts, the second patient is actually doing okay. And, if you're an intensivist or an anesthesiologist, you really wouldn't jump at this patient and would be pretty happy about it. Well, this second patient, has a serum hemoglobin of 7 grams per deciliter. Right? So when we actually look at the oxygen content, not so paradoxically, the first patient is actually delivering way more oxygen than the second patient. So if you measure a serum lactic acid level, for example, the first patient is probably not going to have a high lactic acid level despite the low hemoglobin saturation. The second patient might. Okay, this concept really stresses the amount of knowing the baseline level of hemoglobin in a patient with congenital heart disease, especially if we have a patient that lives at a hemoglobin of 14, 15, 16. We see a lot of Fontan patients in the United States, and those patients, can be very cyanotic. And it's quite important to kind of like bring the hemoglobin back to their baseline. Of course, I'm not going to go into the details of like how to optimize oxygen consumption, but that's the other part of the equation, right? When we have a patient in the ICU that is not stable from a hemodynamic standpoint, we always try and decrease the oxygen consumption as well. So we want to optimize sedation. We want to make sure that the patient is paralyzed, and we want to make sure that we minimize excessive stimuli for these patients. One of the challenges of managing patients with congenital heart disease in the ICU when they become adults is that we deal with a lot of consequences of the surgery or surgeries that these patients have underwent throughout their childhood. Say, for example, that we deal with a patient that had a BT shunt, Blalock Taussig shunt. Well, many of these patients are going to have narrowings of the subclavian artery. And so if you're really not trained in dealing with adult patients with congenital heart disease, you would not think about, for example, the fact that a right radial artery is really not a good monitoring tool because the reading of the blood pressure would be altered. And so you probably need to think about placing an A-line on the contralateral arm to be able to get a better idea of what the true perfusing pressure is. If the patient as a child underwent a cut down, then that area of the radial artery or ulnar artery can be stenosed, and so it's not a good idea to put a catheter in there. If the patient had a prior ECMO cannulation, especially when there were children, and the IJ or the carotid artery were used, that makes it particularly challenging if they need catheterization, both for like central venous access, but also for other procedures like ECMO cannulation when they become adults. If the patient has a persistent left SVC, that is a piece of information that our cardiac surgeons really need to know, because it's going to change their ability to achieve successful cardioprotection, when they go on bypass. Of course, if we have a patient with an interrupted IVC, that is going to change basically where we put catheters for medication infusions and potentially even dialysis catheters in our adult patients. Of course, when we think about patients, especially after the tragedy of Fallot surgery, when their native valve or bioprosthetic valve become stenotic, then if these patients go into cardiogenic shock in the ICU, putting a PA catheter is really not a good idea at the bedside and should be guided by the interventional cardiologist because of the difficulty floating the PA catheter. Another thing that, unfortunately adult intensivists don't think about a lot is the fact that all our patients with adult congenital heart disease might have residual right to left shunts. And so we always need to protect them from air embolism. So having filters that are specifically designated to eliminate air particles and being very, very strict and careful about how we de-air the lines is of paramount importance. Um, Many of our patients after, with adult congenital heart disease um, have arrhythmias, both preoperatively, intraoperatively, and postoperatively. And these arrhythmias are managed in a different way than in the regular post-cardiac surgery patient. So typically, post-cardiac surgery in the adult field, we deal with atrial fibrillation. That's probably the most common arrhythmia, and we see atrial fibrillation with rapid ventricular rates pretty much all the time. I'd say, like in my clinical experiences, 99% of the patients go into AFib. Well, if an arrhythmia, like an atrial arrhythmia, not necessarily AFib, it can just be another type of supraventricular arrhythmia, happens in a patient with congenital heart disease. Pharmacological treatment is the same, but unfortunately, sometimes you just have to be way more aggressive with electrical cardioversion because these patients might not tolerate the loss of atrial weight from a hemodynamic standpoint. Say that a patient has, surgery and they come out with a heart block. It could be just a temporary complete heart block. Our surgeon typically places atrial wires and ventricular wires. But if you lose atrial capture, for example, this is not a patient where you could just place a transvenous pacemaker in the ICU and just float it like you would in a patient with normal anatomy. And so knowing the anatomy of our patients before the patient hits the ICU is actually of paramount importance, way more than when we deal with patients with regular adult heart disease. And then even a more permanent type of pacemaker or resynchronization therapy device is going to be placed in a different way, and it's going to have different settings than a patient without adult congenital heart disease. In my previous talk this morning, we went over the importance of point of care ultrasonography in the ICU, especially echocardiography when we manage these patients. Well, there's a lot of talk nowadays about how to estimate the volume status of our patients by ultrasound. And we need to remember that there's actually no study that proves the ability to do a volume assessment in a patient with adult congenital heart disease in the ICU. For example, there's a nice study that was published on Fontan circulation patients that shows us that, looking at the IVC size in a patient with Fontan tells us nothing about their volume status. So yes, it's so important for the intensivist and the cardiologist to perform echocardiography in the ICU, but it might not give us the same type of information that a patient with a normal anatomy can give us. Another, I guess, common occurrence that we see has to deal with pulmonary complications. So a lot of our patients with either congenital pulmonic stenosis or bioprosthetic valve stenosis, or even more distal stenosis of the branch pulmonary arteries, after surgery are at risk for reperfusion, a lung injury. And that's something that is encountered quite commonly. And in this picture, I can actually show you the evolution from the chest x-ray labeled A. This is a preoperative chest x-ray where you see a little bit of pulmonary vascular congestion, and sort of like oligemic left-sided lung field from a pulmonary stenosis, to the second chest x-ray, which is just a couple of days after the patient arrived to the ICU, where we actually see left-sided lung injury from reperfusion, just having that pulmonary valve opened up, and all of a sudden all the flow goes into this lung that is not used to seeing all that flow, and that triggers, unfortunately, a type of lateral ARDS. And then we see that on the third x-ray, the patient actually recovers, the chest tubes are out, and the patient is ready to go home. Patients with systemic right ventricle are another big challenge in the intensive care unit. I'm not going to go into all the details of these patients because we could talk about that for hours. but I'm just going to give you like the highlights. We always deal with systemic right ventricular failure, and it's not the same as managing systemic LV failure or native RV failure. These ventricles don't respond to inotropes the same way. We deal with systemic tricuspid regurgitation or common AV valve regurgitation in these patients. We deal with atrial arrhythmias in a systemic right ventricle. Atrial arrhythmias are actually a big deal. Loss of atrial contractility might precipitate a significant amount of hemodynamic instability. These patients oftentimes come to the ICU volume overloaded or might have baffle leaks if they underwent a mustard surgery or stenting surgery, during childhood, or atrial switch surgery. Patients with a single ventricle are another challenge in the intensive care unit. These are patients with the so-called Fontan circulation. And we need to remember that their cardiac output depends on the transpulmonary gradient. So the difference between the Fontan pressure, or CVP, their atrial pressure, whether that is a common atrial pressure in a patient with hypoplastic left heart syndrome as opposed to an atrial septectomy, or whether we deal with a patient with congenital tricuspid stenosis, for example, and that's going to be left atrial pressure. Also, PVR management is quite important in these patients. We need to always minimize PVR. So using vasopressors that don't affect PVR, like vasopressin, for example, using inotropes that actually promote a decrease in PVR, like Mirinone or dobutamine, avoiding medications that artificially increase PVR, and kind of optimizing pH and PCO2 for these patients is paramount. Even in the United States, we see a lot of patients that are unoperated, whether they come from the United States or the surrounding nations. So we do see a lot of adult patients with unoperated ASDs, PDAs, VSD, coarctation, and oftentimes even patients with complex congenital heart disease who come. Sometimes they already have Eisenmenger physiology, unfortunately. And these patients are incredibly challenging to manage because they don't have an understanding of their own disease. And of course, other challenges that we're faced with are the fact that a lot of these patients have restrictive lung disease. So managing them on and off the ventilator is different than just managing a simple patient after coronary artery bypass surgery. A lot of these patients develop acute kidney injury. Hepatic dysfunction is quite common, and we might deal with patients with preoperative cirrhosis and portal hypertension. A lot of these patients have baseline coagulation abnormalities that affect the preoperative, intraoperative, and postoperative management. And of course, neurological injury is always around the corner, and it can get potentiated by all the other factors that I discussed. Up until recently, actually, we used to say that mechanical circulatory support was not possible in many of our congenital patients. We're actually pushing boundaries every single day in the ICU I work in, and I've seen patients on mechanical circulatory support that other surgeons in other centers in the United States would have completely rejected, and we're trying to see if we can apply this type of support to these patients and have good outcomes. And so far, we've been able to achieve quite good outcomes. But we need to be knowledgeable about the physiologic limitations of putting a patient with congenital heart disease on ECMO, for example, because you add so many extra challenges to the already existing challenge of having a patient on ECMO. And to conclude, we should not forget about the fact that a lot of these patients have psychological challenges, a lot of social issues. It's very, very common for patients with adult congenital heart disease not to really have a good understanding of their disease or lack of awareness. And oftentimes, there's a lot of barriers for them to be able to obtain the care that they need. whether it's lack of financial support from their family members, whether it's just lack of understanding of how important it is to show up to a cardiologist every single year and get their echo done. And unfortunately, a lot of these patients deal with post-traumatic stress disorder from their previous surgeries. Some of them remember what happened when they were kids, and so they deal with anxiety, stress, depression, and panic. Thank you very much.
I think we are running short of hand. And next speaker will be Dr. Ahmed Nazmul Anam.
No. ছিল না
Thank you. We are running short of time. I heard that, so I'm just start. So my topic is experience of running a PICU in a compromised environment. I'm Dr. Ahmed Nazmul Anam. I am assistant professor. I am from Institute of Child Health from Michael, Dhaka. So before going to the main topic, I must highlight on some topics that is the current scenario in Bangladesh. Pediatric critical care management in Bangladesh is still in its early infancy. The first dedicated pediatric ICU in Bangladesh was established in 1994 in Dhaka Shishu Hospital. Now only 11 or 12 hospitals, including both the public and private sector, are running PICU. Among them, only few are managing their PICUs efficiently with well-trained and dedicated team members along with proper settings. So despite an expected reduction in infant and under 5 mortality and achievement of Millennium Development Goal 4, we still have a long way to go to achieve the Sustainable Development Goal targets by 2030. We are fortunate that among 27 of 138 developing countries achieving MDG 4, Bangladesh is one of the leading countries, and our country continues to be a role model in MDG achievement. So the culture of pediatric intensive care units is focused on curative or life-prolonging treatments for seriously ill children. My friend Nurul Hassan in previous session has cited the problems in an advanced setup like National Foundation. We in ICMH, we have just started the PICU. So I like to focus in the following slides the challenges we faced during establishment and also during the running for the last 1 year. So those working in the PICU in resource-poor nations like Bangladesh perpetually face the challenges of lack of expert support like sub-specialists, diagnostic facilities like laboratory and radiology, and appropriate medications and equipment. So extending vulnerabilities of pediatric intensive care services in resource-constrained settings are being increasingly recognized in the backdrop of predictions about ensuring the waves of COVID-19 predominantly targeting children. And PICU is essentially for the delivery of quality care in pediatrics. So some observation I like to share during the last 1 year while rendering the service of PICU in ICMH Mathuail. Recently, the combination of severe malnutrition, sepsis, and pneumonia with fluid resuscitation in particular has been associated with high mortality. So fluid resuscitation has become a problem, a challenging problem in our settings, which is resource-limited settings. And preliminary data indicate that malnourished patients with shock do show some fluid responsiveness on bolus therapy, but they still suffer high mortality. So this is an experience which we faced. Also, emergency care, including triage and intensive care, is a weak link in healthcare system. I'm not focusing on every healthcare system. I like to highlight on our perspective in ICMH. So emergency and triage training, transport training, simplified protocols, and treatment algorithms have all resulted in reduced morbidity and mortality of critically ill children, thus increasing the focus on the pathways and delivery processes of critical care is very essential. So another point is that sepsis is an important cause of mortality and severe morbidity in PICU. And in this case, also fluid resuscitation is regarded as fundamental to the management of severe sepsis and the beneficial role of early norepinephrine in patients with vasodilatory septic shock rather than dopamine as a first-line agent. We also experienced that. So we have got some challenges which we faced. My friend Nurul Hassan has told previously. Lack of expertise and appropriate medications limitations in PICU medicine and the lack of pediatric subspecialists at ICMH Matwal results in diagnosis and management dilemma every day. A low nurse to patient ratio is known to increase nosocomial infection and patient mortality rates. However, nursing care is still one of shared responsibility with one nurse taking care of 3 to 4 or even more critically ill patients. Recruitment and retention are very challenging. For workforce training, the specialist in our setup has trained 3 months. 2 nurses were trained by pediatric cardiologists through lectures, simulation on mannequin demonstration, and supervised training. We tried what we can do in our limited setup. So low salaries are another challenge. Low average salaries, which lead to a high level of attrition and migration of trained staff to Western countries or private sectors, have also been a problem. Staff members working in these units face many problems every day that stem back from lack of resources compounded by gaps in knowledge and also the supporting system. So we have cited some admission criteria for PICU enrollment. I'm not going to any detail. These are the admission criteria which we have taken. But the problem is we have sent our assistant professors and some problem to train. But however, 3 months of training is by no means sufficient for optimum management in intensive care medicine, especially with the attrition of trained staff to which we alluded earlier. Ongoing training needs to be done, but it might not always be possible, which leads to compromise in quality of care. So transport is also a problem. We know our institution is set up in near Podda Bridge, which is a connection of about 17 districts towards Dhaka. A major impact of the units of ICMH is the increasing transfer of patients from all 17 districts across Podda Bridge. However, 10% are transported in ambulances, most arrive by taxis and certain personal car vehicles. Poor infrastructure and road system only add to the delay in reaching to the ICU. So we have mentioned already this thing. And so these are some challenges which when we face in our ICU system. Too much challenge and examples we can see. The healthcare providers have to work on multiple objectives with a minimal oversight. And also these are the examples we have also said, and we'll discuss later on. This is also a slide which I can share. If you can follow that, the whole team is needed. Here is an example of aortic insufficiency with sepsis patient. So pediatric cardiologist, surgeon, all the teams are needed, and that is a must for running a PICU. But we don't have too many subspecialists there. So based on our experience, which is the topic, we have got some suggestions. So the location for clinical regions. There are a number of critical adjacencies for the PICU. It must be easily accessible to the elevators and to the departments from which patients are usually admitted. These include high dependency units, operating theaters, accident and emergency department, imaging department, cardiac catheterization laboratory, which we don't have yet, and ambulance access. The size, it depends on the such factors like how many ventilators are there, how many PICU patients are transferred, and also the location. Essential accommodation also is a must for smooth running of PICU. And also security measures, that is a problem in our setup. All units should be capable of providing security for the staff and patients. High levels of staffing tend to ensure security in the patient area. Other parts of the unit may be more vulnerable. So security measures include a single entrance with a variety of locking devices and video surveillance. That is a must for running a smooth running of a PIC. So the patient care area will contain a combination of open plan areas and isolation cubicles. A general recommendation is one isolation room for every 2 beds, but this will vary considerably with each institution's patient's mix. And that is we have got some bed position suggestions. Bed should be positioned to maximize patient's privacy. Hand washing facilities should be available for each bed in the open plan areas. In view of the increasing number of surgical interventions that take place at the bed space, a surgical staff sink should be installed for every 8 beds. So a fully equipped resuscitation trolley should be available for every 4 to 6 beds and a separate one for a cubicle area. And at least one defibrillator with pacing facility will be required for every 10 beds. So nursing station, that is also a must, and that would be established in such a way that it commands a clear, unobstructed view of the whole of the main patient area. So in our setup, we have established an integrated family-centered communication into PIC settings, where families are advised to come to us and make a decision towards about their children's treatment. Family-centered practice recommends that the appropriate role for family members for decision-making about goals of care and discussion of end-of-life issues is generally that of shared decision-making in concert with the clinicians. We have some data. We have just started our PICU for the last 1 year. So total 387 was given treatment till 24th January. We have got 3 ventilators. I think this has been a scarcity because most of the government hospitals don't have that many ventilators. In our setup, we have got 3 ventilators, 2 CPAP. We have got 1 very nice eco-portable machine. So we have got infrastructure, but we lack the specialists there. So these are news of our PICU. And not to forget this person which is standing beside me. He took all the pain to run or to establish a PICU. This is our Dr. Nazmul Hossain. He's an associate professor, and I closely observed him how much pain he took to establish a PICU in that limited resource setup. Thank you. Thanks for your kind help. Okay, thank you.
Speaker will be Dr. Shiv Shankar Bastipai. He will be speaking on recent advances in cardiac perfusion.
You can get forward, backward, mark.
Good evening, the moderator and panelist, and I thank the organizing team for inviting me to give a talk. So I'll be talking today on recent advances in perfusion or the cardiopulmonary bypass techniques. So 100 years ago, the surgical treatment for congenital heart anomalies or the valvular heart disease used to be called as a just a pure fantasy. But in 1931, Dr. Gibbon started many experiments on animals, and finally, 20 years later, he did a successful closure of ASD with the use of heart-lung machine. And since then, we have a lot of advances which have taken place now. So let's see what's then and what's now. So oxygenators and pumps, usually oxygenators used to be in the earlier years used to be disc oxygenators and the screen oxygenators and then bubble oxygenators. And I had the opportunity to use the bubble oxygenators when I started my career. And then we now currently are into membrane oxygenators, which we get, which is made up of microporous polypropylene. And coming to the roller pumps, they were being used earlier, and even now they are being used. And now we have the liberty of using centrifugal pump for longer pump cases. But generally, conventionally we use roller pumps as because of the cost. But centrifugal pumps have more benefit when compared to roller pumps. But maybe due to the cost constraints, we may be using the roller pumps. So priming fluids used to be ringer lactate and normal saline those days, but the oncotic pressure used to be a problem, and we used to see a patient being bloated up in the ICU. And now currently with the new this priming fluids available, just like plasmalite A and sterofundin, and we have better outcomes with that. And addition of albumin is also in pediatric is a must now to have an oncotic pressure which is near normal. So the coming to ultrafiltration, there are various types of ultrafiltration, and addition in earlier days we used to use PRBCs more, and we had disadvantages of having high potassium, low calcium, and presence of bradykinin and inflammatory mediators those days. And now we have we can have a ultrafiltration, bypass ultrafiltration, and during the surgeries we can have the liberty of using conventional and modified ultrafiltration. Modified ultrafiltration is most oftenly used in pediatrics to have a target hematocrit of around 28 to 30, so which will be beneficial with the outcome of the patient. So now then we have now the miniaturization of circuits. So those days were the less total circuit, this concept of circuit, this one miniaturization was not there, but currently we have a miniaturization now, which can consistently decrease the size of the total circuit volume, decrease the blood-air interface area, decrease the inflammation, and actively starting mixed program is a very good option now. And heparin coated surface circuits are also now currently available. So these are the advances which we can see now, like coated circuits, miniaturized extracorporeal circulation, cell salvage, then continuous inline monitoring, leukocyte depleting filters, and low prime volumes this circuit, CPB circuits. So coated circuits, as we all know that we have many coated circuits, mainly heparin coated, then the bioline coating, and now current trend is to have the phosphoryl choline coated circuit, which is almost physiological. So coming to miniaturized extracorporeal circulation, theoretically it leads to reduced hemodilution, improved hemostasis, and reduction in morbidity after on-pump cases. And my major difference from conventional CPB include the lack of reservoir and the cardiotomy suction. This leads to significantly reduced tubing length and decreased priming volume to almost 600 ml. So minimal extracorporeal circulation is a closed circuit and involves little or no blood-air interface. Although studies show a difference in the outcomes, some evidence of reduced postoperative bleeding and blood transfusion probability as a result of reduced hemodilution and coagulation cascade activation. So cell salvage, most of the centers do have cell salvage techniques by using a cell saver. It intraoperatively autologous red cell salvage during CPB is an attractive alternative to cardiotomy suction. And the cell saver separates red blood from the plasma and debris by washing and differential configuration, providing a high concentration of red blood cells or no contamination. The salvage blood is then stored in a reservoir containing additional heparinized saline before processing, and which can generally be given back to the patient either post-op or intra-op. So unlike cardiotomy suction blood, centrifugation and washing process reduce the concentration of entire blood cells by almost 20 to 80%, and inflammatory mediators by around 90 to 95%. It is very high when high volumes of blood are processed through a cell saver. There is a depletion in platelets and clotting factors. Careful monitoring and replacement of this may be necessary. So continuous on inline monitoring also is now a trend in India, and I do not know in Bangladesh whether they are using, but India, most of the corporate hospitals use inline technique. So continuous inline monitoring systems use spectrophotometric, optical fluorescence and reflectance based systems to continuously monitor up to 11 critical blood gas parameters with lab quality accuracy. Near real-time results are displayed and can be temperature corrected. Such systems have become a gold standard of continuous inline monitoring. They allow measurement of pH, PCO2, PO2, potassium, oxygen saturation, hematocrit, hemoglobin, temperature, and everything which is required, which is most essential during CPB. So leukocyte depleting filters are also currently used. Activation of leukocytes, in particular neutrophils, is an important step in the inflammatory reaction caused by CPB. Leukocyte removal with specialized filter within the CPB circuit has recently been studied, and the only demonstrated benefit to date is a slight improvement in post-operative renal function. So now coming to low volume CPB, low prime volume CPB, hemodilution resulting from crystalloid priming of the CPB circuit represents a major risk for blood transfusion. So we always try to reduce blood transfusion because of the risk it carries. Retrograde autologous priming is a technique that has been shown to reduce transfusion requirement and appears to be safe and cost effective. Retrograde autologous priming after cannulation of artery and venous retrograde draining of the crystalloid and reservoir and oxygenator helps reduce blood transfusion. So here we, after doing the priming to de-air the circuit, we usually take out the crystalloid which we have added so that we can minimize blood transfusion. So care to be taken because draining too much of blood may lead to hemodynamic instability and an increased risk of myocardial ischemia or infarction. So now then coming to the mechanical support. Earlier days we used to whenever the patient doesn't come off CPB, we usually try to support the patient on heart-lung machine for longer times, and that used to give rise to a lot of complications. But now the recent trend is to have IABP, or even more now recent is ECMO. So whenever patients are requiring, we generally anticipate, whenever we anticipate longer pump runs, we usually put the patient on centrifugal pump so that we can convert them and support them in the ICU's way. Otherwise, IABP is a standard which we use for a shorter support. So now coming to surgically, what are the advances? So we usually have either a conventional procedure, or we can now have a mix, minimally invasive cardiac surgery. And Dr. Ibrahim had already talked about its benefits, risk factor and all, so I'll not be going into that. Conventionally, we usually have a full sternotomy and with a gravity siphonage venous drainage, and cannulation usually will be central, unless there is a redo surgery where you may have to put a peripheral cannulation and go on CPB. And usually myocardial protection is through cardioplegia, which is given either in the root or in the ostium or in a retrograde fashion also. Whereas in the mix, usually it's a smaller incision with a hemisternotomy, and the main venous drainage can be with the vacuum-assisted venous drainage, which can help reduce the exposure for the surgeon. Then we have either a peripheral cannulation, which will be more beneficial because the exposure is very small and you cannot have a central cannulation there. So we usually go with the peripheral cannulation. And cardioplegia usually can be given through a long cardioplegia cannula, which is inserted to the thoracotomy, or you can use an aortic balloon clamp, which deals like with we can usually use that as a aortic clamp and deliver cardioplegia as well as vent it. So, but it is very expensive and not all centers can use that. So cost, because we being in a country where we usually get from with the economically or financially backward people, so we may not be able to use these expensive gadgets. So incision usually, as I told you, it is either in a conventional, it's full sternotomy, and in other mix, it can be a different various ways, or either an anterolateral thoracotomy or a hemisternotomy for various procedures. This is a cannulation, either it can be a central or a peripheral, depending on the type of surgery. And this is a venous drainage, as I told you, a vacuum-assisted venous drainage, or a conventional, even kinetic venous drainage also can be used. And cardioplegia here, as I told you, that we can use a longer cardioplegia for a mix, which is inserted to the thoracotomy, or it can be through a endoaortic clamp, which can be passed through the femoral artery and placed there. But only thing is, you cannot use this cannula for a aortic insufficiency patient, where you have to use a directly coronal arterial cannula and deliver cardioplegia. So what I have seen here, I think the main thing is about cardioplegia. Either a Saint Thomas or Del Nido can be used, but I have seen here the center is using more of Del Nido cardioplegia. Yeah, only Del Nido. So I feel, because Del Nido usually started with pediatric more, but now I have seen, even in India, I don't think any center is doing only with Del Nido cardioplegia. I think the perfusionists here should present some publications, or they should do some study and present it, because that's a very good, I have never seen in India somebody using 100% Del Nido for an adult case. So I think it is high time for the perfusionists to present it and do a study and present it. So that's it. Thank you very much.
Professor A.K. Shamsuddin. I'd like to invite you, Professor Shamsuddin Sahib. Nik asen niki? Oh, okay. What's your name, please? I must mention your name here, you know. Okay, Dr. Istiaq will present on behalf of Professor A.K. Shamsuddin. Where?
Sir,
Yeah. So we are going to handle next the future of
আমার কাছে
That's too much.
স্যার প্রেজেন্টেশন ফাইল
last session 6.
লেফট রাইট forward in the course. Yes.
Assalamu alaikum, everyone. As you have already heard, that this presentation was supposed to be delivered by Professor A.K. Shamsuddin, sir, but he got stuck with an obstructed TAPVC, and so he had all the intention to come over here, but he just informed me that I have to just present this on behalf of them. Actually, he had a lot of vision and, of course, a lot of wisdom within this presentation. If he would have done it, and of course, those will be missing in this presentation. Well, I'm going to present this thing. I beg apology for this at the beginning. Well, if we consider the economic status of Bangladesh, we know that Bangladesh is having a GNI per capita of 2,824. So it is in the lower middle income country. But this lower middle income country has a very huge population, and as a consequence of that, the child birth per year is almost 48,000. And of course, it makes it the second highest cause of mortality in case of infants in our country. But if we consider or look at the healthcare budget of Bangladesh in 2022, we will find that only 5.43% of the total budget was allocated for the healthcare sector, let alone about the caring the patients with congenital heart disease. And of course, out of 32 cardiac centers who were providing cardiac facilities throughout the country, only 6 have a dedicated pediatric cardiac support. Regarding the neonatal and infantile pediatric cardiac surgery, as we know that there is a big spectrum of disease that might with which the patients might come. And of course, these are the diseases where the patients used to come very early of their life. And as a neonatal cardiac setup cannot be developed probably as in a first setting, but it had to be grown over the time. Pediatric cardiac surgery of National Heart Foundation was started its journey in 2010 with the adult program, and that time almost the age of the patients were far more than what we are used to doing right now. And gradually, we have moved in 2016 to our separate building where we had 2 separate OTs for the congenital cases, and we have a dedicated big ICU for the kids also. And in 2022, we had a collaboration with Children's Heart Link, which is a philanthropic organization helping the cardiac patients worldwide. And as a result of which, we are performing almost 800 cases yearly. And last year, we have done 812 cases. And of course, the number of neonatal and early infancy surgical patients are rising over the years. As we can see, in 2017, it was only 17%, and in 2021, it was 38%. This year, it is 35%. Well, a lot of challenges are there to establish a pediatric cardiac program, and those are, of course, the completing the health care priorities, getting trained doctors and other manpowers, retaining manpowers, affordability, financial burden, lack of funds, infection control, education, research projects, and nutritional status of the patients. A lot of problems, but of course, if we just remain with those problems, the solution will not come. We have to think, we have to make a way out of it, and we have to act on it. Then we will get our desired result. So in this slide, the thing that we try to show over here is that if we consider Bangladesh over here, the second most incidence for which there is infant mortality is congenital heart disease. In fact, we know that there are the government and other NGOs are cautious about the respiratory tract disease, diarrheal diseases, and they have a lot of programs to improve those things. But for congenital heart disease, there are very few. So there is perhaps scope to do this. And of course, getting trained manpower is a big challenge, as many of my previous speakers have shown that we have a very limited number of surgeons and very limited number of intensive-based professionists working in the field of pediatric cardiac surgery and pediatric cardiology. And of course, trained nurse is a very big issue for us, which is, of course, the backbone of doing this, treating these kids. And same thing also with the pediatric anesthesiologist and pediatric cardiologist. Retaining manpower is a big issue that has been repeated again and again in this conference by several of our speakers. And affordability and financial burden is a big challenge for a country like us. There are private partnership like National Heart Foundation is definitely a good example. But along with it, government, NGOs, or other personal and other philanthropic organizations must come up to improve the situation. A continuous training, education, and research should go on to improve our facilities. And in our setup, in fact, MD/MS courses, fellowship trainings for the doctors and nurses from other hospitals, regular morning sessions, doctors going to abroad for training are a routine facilities that our hospital tries to provide. Some foreign collaborations are also required, and as I have told you that for last year we have a collaboration with Children's Heart League, who have collaborated us with the Leeds Teaching Hospital, and through their visit to our hospital, they stayed for 7 days in our hospital and gave us a lot of teaching, which are really helping us to improve ourselves. And to do all those things, in fact, maintaining a harmonious teamwork is a very important issue. And to do this, we have to avoid blame games. We have to have mutual respects, and we have to have a joy and playful and cordial environment for working. In the conclusion, that can be said that commitment of the government is a very important issue. Strong desire of the hospital is very much required, and efficient leadership is a must. And of course, a group of enthusiastic and devoted people are mandatory to develop and grow and continue a pediatric cardiac care. And this is our lovely, beautiful team. I would rather say this is our family with which we work and try to grow ourselves. Thank you all.
Last of all, I would like to invite Dr. Jannat Firdaus. Is she there?
প্রেজেন্টেশনের ভিতরে ভিডিও আছে
Assalamu alaikum. Good evening. Assalamu alaikum. Good evening. Shubha Shandha. First, I would just like to thanks to my departmental head Ajad sir and Selim sir to give me this opportunity. I am Janatara Firdaus, now going to present my case. Actually, this is funny, but it's true. When we are dealing with our boss, it's always challenging. And the cause is all about the baby boss. My topic is Challenges of Pediatric Cardiac Anesthesia in a Resource-Limited Center. The pediatric cardiac anesthesia is an exciting, technically demanding subspecialty in which anesthetic management is based on sound physiologic principle. Congenital cardiovascular surgery and anesthesia are often performed under unusual physiological condition. Good practice in anesthesia for congenital heart surgery in children, whether for palliative or corrective procedure, requires an extensive knowledge of the pathophysiology of the particular disease process, the effect of and reaction to the drugs, processes of anesthesia, and likely outcome of surgery. Pediatric cardiac patients are cared for in specialized cardiac intensive care units in multidisciplinary intensive care units. The history in Bangladesh, first pediatric cardiac surgery was a case of ASD done in 1984 in our hospital. First pediatric cardiac anesthesia that is given to this patient. Our Khalilur Rahman sir and ATM Khalilullah sir was present at that time. Pediatric diagnostic cath done in 2002 and first pediatric therapeutic cath done in 2005, which was a case of PDA, 1.5-year child done by Professor Salam sir. Government approved pediatric cardiac surgery in our hospital as an isolated unit in 2004. And as a pediatric cardiology department, along with 44 bed, it was approved in 2022. Real scheme in pediatric cardiac anesthesia. In Bangladesh, actually there's no post-graduation course in cardiac anesthesia as well as pediatric cardiac anesthesia. We don't have any academic facility, training as well as fellowship for this subject. This is the only government institute where we provide as well as learn pediatric cardiac anesthesia under the guidance of our senior colleagues. Incidence: congenital heart disease refers to structural or functional heart disease present at birth. Incidence of congenital heart disease is the rate that refers to the number of children born with congenital heart disease related to the total number of births over a period of year. In Bangladesh, the incidence was found up to 25 per 1,000 live birth 1 year. And infant mortality rate is 54 per 1,000 live birth. 8 common lesions, up to 80% of all congenital lesions. Among them, the VSD is 30%, PDA 10%, ASD 8%, pulmonary stenosis 8%, coarctation of aorta 6%, and transposition of great arteries 4 to 5%. And remaining 20% is made of a variety of rare complex lesions. Challenges of pediatric cardiac anesthesia: the perioperative care of the neonate, infant, and child with congenital heart disease requires a coordinated multidisciplinary approach to patient care, which include the pediatric cardiac anesthesiologist, pediatric cardiologist, pediatric cardiac surgeon, pediatric intensivist, pediatric nurses, advanced practices nurses, physician's assistant, respiratory therapist, and family member. Each member of the team brings unique knowledge and perspective to the care of the patient, recognizing and integrating all members of the team in the ongoing care of the patient are essential in providing optimal care of this patient. And what are the challenges we face? The shortage of trained personnel, the main thing. We have previously been exposed not only the challenges of providing safe pediatric cardiac surgery, but similarly to the challenge of providing safe general anesthesia to pediatric cardiac patients. The major challenge is lack of dedicated and sufficiently educated pediatric cardiac anesthetic team. Limited diagnostic facility with resource person. In our country, detection of congenital heart disease will be delayed due to limited diagnostic facility. So after detection, when patient come to us for correction, the chance of morbidity and mortality will increase, which will be challenges for both anesthesiologist and the surgeon. High patient acuity. NICVD is a highly regarded center as well as it sees high volume of patient, which can put a strain on available resources, including staffing, equipment. Patient may delays in receiving their surgery, even they need 2 months or 3 months in serial to get the surgery. Lack of beds, inadequate finances to pay for the treatment. Financial constraint. Despite the high reputation of NICVD, access to its services can still be limited for some families due to financial constraint, as most of the people come from low socioeconomic condition. Equipment facility. Without advanced facility, we can't go through. These are the availability of pre-induction room, limited access of different variety of laryngoscope, ETT tube, fiber optic laryngoscope, ultrasonic guided procedure, pediatric transesophageal echocardiography, along with skilled personnel, cardiopulmonary bypass machine, then ECMO, room temperature for well maintenance of pediatric cardiac patient as well as humidity, availability of ABG machine and working capnograph, availability of emergency drug, availability of biomedical engineer for maintenance. Even some operation postponed and cancelled last year due to limited access of oxygenator. Standard protocols for pediatric cardiac anesthesia are essential for ensuring consistent and high quality care, but may not exist in resource limited center. Providers may rely on their experience, judgment, which can lead to inconsistent in care. Infrastructure. Adequate infrastructure such as pediatric cardiac emergency department along with pediatric cardiac intensive care unit, pediatric pre-anesthetic checkup room, pediatric pre-operative room as well as post-operative pediatric cardiac surgery ward, standard operation theater for pediatric cardiac surgery. Ultimately, standard dedicated pediatric cardiac anesthesiologist as well as surgeon, regular availability of all disposable accessories and functioning equipment is essential. This is our dream. We want a dedicated pediatric cardiac anesthesiologist, dedicated pediatric cardiac surgeon. Our dream, these pictures are taken from some corporate hospital. This is not our hospital's picture. This is our dream, a well-established PCICU, inshallah in future. Well-established PCICU. We just collect these pictures from my friends from corporate hospital. This is, and this, and this, and this is our limitation. This is our PCICU. This is our pediatric cardiac surgery department. This is nice. This is newly actually occurred in 2022 with 44 beds, so it's nice. I like it. This is the feature actually bed with 2 occupied patient because we don't have too much patient. Too much bed actually. This is one patient's mother. She's Parul. Actually, this is a video, I think. It doesn't play. Yes, just hear what she says. Yes, this is maybe. Okay. So actually, she's come from a long distance from Jamalpur maybe, or she said she doesn't know her daughter didn't cry properly, so she's confused, and the diagnosis of VSD along with Down syndrome hypothyroidism is diagnosed after 1.5 year. I mean after 1.5 year, and she is just round and round from here and there for treatment purpose, and go to some corporate hospital, but she's low socioeconomic condition. She doesn't have money, so then she come to our hospital when her child is 4 years, and done this. Look, this is the feature at the day of operation. We did this, ICU, and this is our success. Look, this is also a video. What she says, thank you, but today is no video day. Okay. And number of operation performed in 2022 in our hospital. TOF, I mean tetralogy of Fallot, 6.03%, BSD 9.67%, ASD 17%, ICR 14%, BDG 0.84%, closed heart 7%, cath performance 45%, and death for 4.22%. This is in 2021, we did 456 operation along with cath, and 2022, 828 operation total, and death is 4.22%. This is our cath performance. Cath lab done in 2022, ASD device 39%, BSD device 4.28%, PDA device 44%, cardiac cath 12%. In January 2023, in our PCICU, 64 patients admitted and 17 patients died due to variable cause because we don't have any setup for infant and neonate. In conclusion, despite these challenges, NICVD remains committed to providing high-quality pediatric cardiac care, including anesthesia, continuously strives to improve its capabilities, resources through ongoing investment and technology, staffing, and infrastructure. NICVD is well positioned to provide effective and safe pediatric cardiac anesthesia to children in need. We are doing work in government sector, so there is some lack of facilities in comparative with private sector. This is our limitation. Ultimately, this is the mother institute for all the cardiac anesthesiologists as well as cardiac surgeon. And this is the ultimate truth. Thank you.
Everybody is waiting for a cup of coffee. So before that, I'd like to say that the whole session is miscellaneous session, and the presentation was based on compromised situation. So therefore, the question is very less likely to be less question from here. There's only one presentation which was on the positive side was the advances in cardiac perfusion. The rest of all the lectures were in a compromised situation. So, is there any question from your side on any issues, any subject that have been presented? If you don't have, we can go for the CREST program. No? Okay, no. 1 second, 1 minute is gone, so we'll go. Finish. Let us go for the CREST now. Once CREST is given, we'll go for the discussion.
One question to Richard Hopper, because in technology of fellow, that managing nicely, I think he has shown how he's managing the technology in his center. But one question, what is the quality range of technology fellow managing your center? What are the reasons of this?
I think Judy probably better
Okay. Let me finish. Once we finish the crest, we'll give you the podium to speak on this question. Okay, we'll give the floor to you. Just for a few minutes.
Now you decide who will answer. Who will answer? Who will answer? Where to answer?
Okay, you answer.
Okay. So, first follow, Dr. Ahmed Nazmul Anam, please pick up your quest from Brigadier Mujibul Haq. He's a cardiac anesthetist in Ismail Hospital. Done? Shiva Shankar Bastafai. You'll pick up from Professor Sharia. Please come here.
Sir, let me touch. Please.
Ashwa.
Thank you.
Thank you. Our next recipient will be, on behalf of Professor Dr. A.K. Shamsuddin,
What's the name?
Dr. Ishaq, tall man. Please come and pick up yours. From Ashfaq, please. From Ashfaq will give it.
You are giving your pain.
Done? Okay. Dr. Janata Firdaus, who has been very honest with all the words, so you can come here and pick up it. Okay. No, I'm sure come on. Please.
All the way.
I would like to invite any one of them from here who will answer the questions of Professor Salim. Who is going to Hey, speak of the mic is out. Use the mic.
I apologize for being a little flat-footed on the answer to this one. None of us work specifically in the pediatric ICU at this point to give you an honest answer. What we all seem to remember is that none of us have a memory of having lost a TET in the last few years at all. But it's probably a very low mortality rate, 1%, 1.5%, something like that.
So, if there is no other question, we can move forward with our panel of experts who will make some comments. And I will start from Dr. Colonel Ashfaq. He will make some comments on the speakers that we spoke on.
Okay, thank you, sir. It has been a long day. I will not prolong the session. So we all know that the adults who are landed to the cardiac surgeons with congenital heart disease, they already have 1 or 2 more surgeries in their childhood, and most of them are complex. They need a proper understanding of the pathology and physiology. So the integral part of the management, I think, is that the proper integration and interaction between the cardiologist, intensivist, and the surgeons. Otherwise, the treatment goal will not be fulfilled. Whichever the setting it is a high-end setting or constraint setting. Okay, Dr. Diago has presented nicely. And truly, Dr. Nazmul has said that in the background of the COVID-19, the recognition of PICU in our country is growing, and I hope that in next few years it will be increased. And the main issue is that the challenge will be to fulfill those ICU with proper trained intensivists and with the equipment that required to fight with the situations. And the intensivists always fight with their limitations to fulfill and to achieve the goal. And the cardiac anesthesia in our country also has advanced from its primitive to the adult stage, and state-of-the-art cardiac anesthesia is being provided to the patients. The only thing is that we have limited centers to provide. And for the neonatal surgery program and also for the PICU or pediatric cardiac ICU, the first thing that require is the commitment of the administration and the hospital. Unless it will not be successful. Even in our center, that is the combined military hospital, is a mature center and having cardiac surgery for about more than 2 decades, but still we are not going. We are not able to start the neonatal surgery. So the trained manpower and the commitment from the administration is the paramount requirement for a successful program. Thank you, sir.
Thank you, sir. Thank you, all the speakers. In the dawn, or I think I have little thing to talk about. I'll just glimpse, thank that we came to know some advancement from from the speeches of, I think, Shiva Shankar. That's the amazing things that we came to know about the oxygenators, like bubble oxygenators, memory oxygenators, but I think it's unfortunate for us. We're now struggling for oxygenator in Bangladesh at this moment due to dollar issue. So these are the things, the two ends, two horizons. The Hubbard that like to say that the north are going to uprising and the other end of the world we are in darkness. So I think they'll come forward with hand to hand. We'll work together, and others. And also I'll address the Tiago Casali. He has given all the challenges, mechanical supports like anatomical changes, physical limitations in doing surgery, adult surgery. We have seen the one end of the surgery, and there is another aspect of the gooch that is known as anal congenital heart disease. And last of all, other speakers like Anam, he has given us the glimpse of the newer center. They are going to build up the newer challenges. I think they will come up in the next following years. They have some struggle in the primary period, and then they'll come across all these odds. And Professor Samsuddin, he has shown us how a little middle-income country surgery program. It's a very organized institute. Actually, in Heart Foundation, they're with the help of some, I think, other charity, and they are going to set up their institute. And we wish their every good days in your future. And last of all, Jannata Firdaus, she is our regular mate. I think I'm thankful to anesthesia department in NSCVD. You know, NSCVD is the only public institute in Bangladesh, largest. But we have some limitations. But the peoples that are working here, though there are some limitations, there's some, I think, efficient energy. They have some. So with their energy and I think with little resource, they're working here. So for Jannata, the way he has depicted the challenges in anesthesia, we have some, don't have some equipments, or don't have some drugs. In the cath lab, the schedule hour is limited. We work only, we can utilize after 24 hours, only 6 hours for cath lab. I think now we can understand what we can do. So I think their days will be changed. The sun will rise in that and the end of the horizon. So I thanks everyone. I take time. Thank you very much.
Hello. So thanks to the learned audience for sitting long time, and I will start my making comment on the reverse direction. It's not that I'm anesthetist, the Dr. Jannatullah Firdaus. I congratulate them for presenting an excellent way, and I request her that dream has already coming true, as because this is a really a wonderful session. As because who could think that a couple of weeks or months such a beautiful conference could be arranged involving the cardiac surgeon, cardiology, cardiac anesthetist, perfusionist in a limited resource country like Bangladesh, because we know that cardiac surgery, not only cardiac surgery, the pediatric cardiac surgery, to tell about that, the pediatric surgery is so much so involvement, so much dedication is required. So who will come forward? So inshallah, we are coming forward with this program, and I must congratulate Dr. Selim and all other things for coming forward with such a beautiful session, day-long session, inviting foreign delegates. The next one is Dr. Shamsuddin. I know him very long, since long. He's a very dedicated pediatric cardiac surgeon in the country. So and everybody know about him, and his presentation also is very informative. And Dr. Shiva Shankar Basti, yes, in a cardiac surgery, and what to tell about the pediatric cardiac surgery, the single most important thing is the perfusion. It's so much so important. It requires so much so calculation, so much so dedication and thinking. Many times in my career over the last 20 years, I have seen that everything is smooth, surgery was done perfectly, but because something went wrong during perfusion and the patient died, or the outcome was very reverse or onwards. So this is so much so important that when a perfusionist comes forward with his advanced knowledge and advanced technique, definitely it will going to make the life of a surgeon and the whole program is a successful one. Then Dr. Anam, yes, definitely salute to the doctors, including Dr. Anam, who all are performing in our country and who are establishing new and new things like this pediatric ICU, neonatal ICU, because unless otherwise you have dedication, you have real interest, you cannot do these things. But definitely, I salute you and the young doctors. Then Dr. Diego Casilli, yes, he is what I guess is a very learned and experienced intensivist who is lacks in our country. Yes, we have got 30 cardiac center in our country, but so far I know none of the center has got a dedicated cardiac intensivist who looks after solely on the operated patient in the ICU. No, who looks after either surgeon or the anesthetist, who is definitely, he is busy otherwise. He is committed at the end of the day, because the patient comes in the ICU in the end of the day, and the anesthetic again he's coming to ICU to establish the patient, hemodynamics, all these things, and he's going home, and next day he's thinking about the next day. So definitely, what I've seen in the home and in the abroad, that a cardiac surgical program requires a dedicated cardiac intensivist, who is definitely lacks in our country. So I request authority to develop these things, and I also pay my gratitude to the my foreign colleagues who has taken all the travels to come over a long distance, and who make the day very successful one. Otherwise, without you, would not have so much successful. Thank you very much. Thank you, everybody. Thank you, sir.
Last of all, myself, I have to moderate my own moderation, so I couldn't moderate them. So I'll make this speech very short and quick. I want to make a very close relationship between Dr. Hubert's lecture and my personal discussion while I was having a lunch, and the miscellaneous presentation in the last session, and my personal connection with these two issues. Issue one, being at the National Heart Institute, National Institute of Cardiac Surgery, NICBT, is the first cardiac center in Bangladesh. And I started working in that institute since 1981. And then I completed my job in 2011. So I was continuing the same place. So what happened, there was a transitional situation. During the earliest stage of establishment, the entire cardiovascular team was working on congenital heart disease and valvular heart disease. So what happened, because there was no echo, not a good echo, echo, no echo means on the M mode or 2D, and most of the cases were diagnosed through cardiac angiography, almost all, even to valvular disease. When all the experts have become familiar with the surgery, congenital structural heart disease surgery and valvular heart disease, in the meantime, coronary bypass surgery has become an top of the world. Oh, but the people who have been exposed to this valvular disease, they are now trying to shift from that area of cardiovascular disease to the coronary bypass surgery. And suddenly, there was not much trained people in this field at the time. So everybody rushed over there. In the meantime, fellows have been produced in a good number, but no space to be employed anywhere. See the situation. So there's a long time has passed, and few has developed bypass. One, bypass surgery patient economically sound, and the structural heart uses economically sound. So after giving so many years for their career, the income has become a challenge for them. That if we go for the coronary artery, the chance of survivability will be better. A big chunk of structural heart disease remain left out. When cardiac CVG was going on, in the midst of this scenario, the device closer has arrived. So is the stents and angioplasty. The cardiologists who are supposed to be part of the structural cardiology, they are shifting towards intervention cardiology. The pediatric cardiologist is still going on that. So it's cardiac surgery. When the device has arrived, then some few cardiologists wanted to do some device. Once device has taken place, slowly and gradually, some young people is trying to go to the cardiac surgery. And the result was what was that? The result was after 50, 30 years or 40 years, the number of cardiac surgery, cardiac anesthesia, and structural heart disease is very. Now the stent is matured, CVG is matured. Therefore, the big area is now lying is the pediatric cardiology in the field, and good number of surgeons in the field. So we'll get good number of surgeons for this surgery also, because 2, 3 NSCVD and the BS, I mean, our we are producing good number every year, but they don't have the employment base is not very strong nowadays still. So there is a chance of picking these boys out of those areas and then put them into pediatric surgery. My point is to whoever is lecturer is this: you have been offering this where to improve, where to support. The support is in structural heart disease, because again, in courses the postgraduate doctors will not qualify in examination without going through the cases on structural heart disease. They have to know the murmur, they have to know the diagnosis, and they have to pass through the. So therefore, what I like to get your attention, you can explore. And the manpower is still in the market, because many of the cardiac surgeries are not well placed. You don't have to specifically. So you can expand this area in a very wider perspective. Perfusionists from Bangladesh should also present next time, and then make yourself comparative what you will like with the Indian. He has presented perfusionist area is still very weak in our country. Yes. So I don't like to prolong my lecture in this last one fag of the meeting. Everybody is tired. So I have killed that area. So let me conclude this. Thank you very much to everybody for coming. I don't have to talk so much. You have the concept. What went wrong and how it can be corrected. I'm living, I'm living to know the whole past, and I was. Thank you very much for this. Thank you very much.
And that brings us to the end of first international conference on perioperative pediatric cardiac care. Thank you all for your kind cooperation. আগামীকাল যারা ওয়ার্কশপের জন্য রেজিস্ট্রেশন করেছেন, অনুরোধ করছি তাদের সকাল 9টার মধ্যে 4024 নম্বর রুমে উপস্থিত থাকার জন্য।